Well, welcome. I'm Ruth Burcaw, and I'm the Executive Director of the Board of Cooperative Ministries of the Moravian Church in the Southern Province, North America. Today, we're happy to share with you some information about the latest information about COVID-19, particularly as it relates to some of the V's, the variants, the vaccine, virus transmission, things like that. And we're glad that you're with us. Our format will be we'll hear a little bit from our speakers, and then they will address some of the questions that have been turned in advance. And then we'll open it up for questions that you all may have. And as questions occur to you, feel free to put them in the chat during our conversation. So I'm happy to introduce to you now the Reverend Keith Stirewalt. Keith is the program manager for FaithHealth at Wake Forest, Wake Health. It's hard to keep up with all the names, but at Wake Health. And we really appreciate Keith. He is an honorary Moravian with us as well, a member of HOME, and has been here before for various webinars. And we really do appreciate his expertise, which is multi-layered as a health professional, as a hospital chaplain, and an administrator, working basically at the intersection of faith and health. So Keith, I'm going to turn it over to you and let you introduce Dr. Bischoff and get us going here. So thanks so much for being with us.
Well, and thank you, Ruth, for the invitation and for putting this together. I'm pleased to introduce today's speaker, Dr. Werner Ernst Bischoff, MD, PhD. He's the Medical Director of Infection Prevention and Health System Epidemiologist for Wake Forest Baptist Health. He studies the spread, control, and overall impact of infectious disease and oversees the infection prevention and control activities of Wake Forest Baptist Health. He received his medical degree from Germany, his master's in clinical epidemiology from Wake Forest School of Medicine, and he has a PhD in epidemiology from UNC Chapel Hill. And during this time, the time of COVID-19, he's a very popular man, and we're grateful for the gift of his time. Welcome once again, Dr. Bischoff.
Yeah, thank you very much for the introduction and also for the invitation. So I want to give you a brief update and hopefully address some of the questions that are coming up now with the vaccination in full swing, with COVID-19 still going around, and with variants, etc., that we have to deal with. Let me see if I can actually share my screen, which would be very helpful for a presentation. Let me see if that works. Okay, I hope you can see my screen. And I take it as a yes. So let's start with that. And
Good.
So that doesn't work. Okay, great. Where are we? And this is just kind of a few numbers here for where the pandemic is. So you can see close to 124 million confirmed cases worldwide, with over 2.7 million deaths. And as you have heard, probably second or third wave or fourth wave in Europe that is going on. So definitely troublesome looking at our entire planet and COVID-19. So not over yet, unfortunately. So in the United States, we have now close to 30 million confirmed cases with over 542,000 deaths. And then on the right side, you can see kind of the graph there. The red line is the 7-day average of new cases. And you can see how it actually kind of peaked there around then starting in November, and then February, kind of end of January, kind of fell down then to the levels that we were actually kind of last year around July and August. So, and it's also kind of a little bit leveling off. It's something that we greatly appreciate to see actually kind of the drop in new cases, but it's also kind of worrisome that it doesn't go really down as quickly as one would wish to go, maybe kind of to the May or June levels that we had before. So I put in there also the spring break and impact. So we will see how that goes, looking at Miami and Miami Beach and all the stuff that they have to work with now in Florida. So we will see how that actually kind of translates in the spread of COVID-19. As you know, most of these folks could not get vaccinated. They are not in the target groups yet. So it will be interesting to study that, how that will impact the communities that they are coming from. So the average daily cases, I have these slides kind of for pretty much all my presentations, and I can tell you that looks a lot better than it was in January. Then it was pretty much dark red, and here you can see kind of the lighter colors coming out. And if you look at your area there where you're kind of coming from, you can see kind of where it is. But definitely a great trend just from the color mapping here. So in North Carolina, where are we? We pretty much follow exactly what kind of the nation does in cases. So we have close to 900,000 cases. The hospitalizations really went down. I have a slide for that too, but the death numbers are really high with 11,836 as of yesterday. So that's the status for North Carolina. Again, very nice light colors. So we see not a lot of new cases right now. And these are the hospitalization numbers, and you can see that's for North Carolina, 7-day average again, and you can see how it dropped down here. And again, very good signs. We are seeing less and less patients here in our hospital, but we can also see that we are leveling off again. So we are around now 40 patients here in our system, kind of on, but it doesn't really go down further. So we have to be aware that this may be actually kind of something that is a trend that we have then to follow up. So let's talk about the virus, and you have heard a lot about mutations and variants that are coming out of it. And this is pretty much kind of a slide that explains a little bit kind of the lingo that we are using in the medical profession to figure out, okay, what it is. All these mutations right now affect the spikes here. So these red dots that are coming out here out of the coronavirus. And so these mutations change actually the structure of the spikes. And the spikes are important to attach a virus to a human cell and then allow the virus material to actually get inside of our human cells and replicate then inside, etc., infect pretty much our system. So if you look at that here, mutations that are passed then through branches of a viral family tree are called lineages. So, and then again, if you have a group of lineages that are kind of coming in there, a set of mutations, then it can be called a variant. And if a variant is distinguished enough from other virus strains that we have, then it's a new strain. So the SARS-CoV-2 is actually a new strain of a coronavirus that we didn't see before. That's just kind of for the lingo that we are using here. So the mutations, what can they do actually? And again, you can see the model here on the right upper corner. You can see these red dots that are coming out. These are the spikes again that attach to the human cells. And then you have kind of a big blow up spike, actually kind of how it looks like. And you see all these wonderful letters they added, Y144, 145, etc. These are points where mutations are happening. So they change actually the structure, the attachment points to the human cells, but also change actually how antibodies that our human body produces to fight these virus particles, how they can actually recognize the virus and attach to it. And the fear is actually kind of that these mutations lead to immunity, so our system cannot recognize them. And again, the virus would be replicating without any inhibition and make people sick, lead to hospitalization and even to death. So these mutations can actually kind of alter the transmission dynamics of the virus. So that's known for the B117 that has been first recognized in the UK. And it can also increase severity of illness, which again is the case for the B117, or what I just told you, can make vaccines less effective. So, and several of these lineages have been detected, and you can see here from the B117 down to the mutation E or EEC here that they call it in Portland, Oregon. All of these affect the spike protein, and we have to kind of look at them very closely to see what impact does it have, especially for our vaccines, how effective they are. Now, our current vaccines that we have, that is the, of course, Pfizer, BioNTech, the Moderna, and the Johnson & Johnson single-shot vaccine, all these produce actually polyclonal responses. That means that you don't have just one type of antibody, you have a lot of different types of antibodies. So, and again, that is very nice because it covers a wider range of mutations that the virus can come up with. So here are mutations, and I just want to give you kind of a timeline here, what happened, and you can see new ones are popping up in New York City. The B15261 one, the EEC one was in Portland, Oregon, just kind of detected, etc. So again, a lot of movement there and a lot of potential for the COVID-19 virus to mutate in a way that our vaccines are not effective anymore. So it's a race, and I will use that term again. The quicker we can people vaccinated, the better the chances are that these mutations actually are not happening, because you are reducing the pool of patients and persons that are actually kind of carrying the virus that inside of them is mutating. So let's talk about vaccines. And you can see here the phases of it. And again, very safe kind of, we are following exactly these kind of phases. So the vaccine development didn't take shortcuts, but they actually kind of used the time frame to really kind of do some of these parallel testing to make sure that they are very safe. And you can see the phase 3 here, thousands kind of the Pfizer vaccine, Moderna vaccine, and Johnson & Johnson. These were kind of 30, 40,000 folks that are actually given the vaccine to look at the safety of the vaccine and also the efficacy of it. So where are we with all these? And you can see here 78 vaccines are clinical trials on humans. So the 3 ones that are right now approved here in the United States are not the only ones that are coming down the pipeline, which is really nice because, again, the more vaccine we have, the better we are positioned in our race to fight the virus. And you can see here 7 approved overall, and at least 77 are in preclinical trials or investigations in animals. There are some vaccines, the 4 here, that have been abandoned. Merck had one that didn't turn out to be effective. So this is not all kind of a take it all and everything will work. This is kind of really high science, and the research that goes into it is phenomenal. So some stuff, sometimes it doesn't work, but also it's kind of a thing to reassure people not everything is just kind of going through. So these are the 3 vaccines that have been approved here, and you all know that the Pfizer and the Moderna are 2 shots here that are required. The efficacy rates of the 2 shots is very high with 95% or 94%. The only problem with these vaccines are that you really have to keep them cold. Yeah, so it's a logistical nightmare to give them out to the population because you have to make sure that they are in special containers, in special freezers, etc., that go down to the temperature that you need them to be. You have 2 hours to thaw them out, and then you have to give the vaccine, and you better make sure that everybody gets the vaccine when you have thawed them out. You don't want to throw anything away. Johnson & Johnson is a different vaccine makeup. So you see here the messenger RNA kind of from the other 2. This one is double-stranded DNA vaccine. And again, it's using actually kind of an adenovirus that comes in there as a transfer vehicle. These adenoviruses cannot make you sick. They're just used to pretty much get the information into the cells there, where then the cells producing the antibodies. The same for Moderna and the BioNTech one. This messenger RNA is not actually integrated in your genome. It's not a gene therapy, etc. The messenger RNA is a very flimsy construct that pretty much falls apart when you look at it. And so it is really kind of the modern technology that went in there to get it actually into the human cells. It's amazing to get that in there, but the messenger RNA is just used to transcribe to produce the spike proteins, but then it falls apart. So there is nothing that's integrated in your genome that you can give to your kids or that stays with you. So the Johnson & Johnson, again, it's a single dose, which is very nice to give. And also the refrigeration here is really kind of nice. You can take it home and store it in your refrigerator if you like to, if you get your hands on it. That's the other one. And the efficacy rate is also really high with 72%. So people are starting, oh, wait a second, I can get a vaccine that is 94%, and now you give me one with 72%. All of these vaccines, the biggest goal of these is to keep hospitalizations down and to keep deaths and severe outcomes down in these patients. And all of these are working exactly in the same way. The Johnson & Johnson and all the trials pretty much had 0 hospitalization and severe outcomes for the COVID-19 infection. So this is fantastic. Some had mild symptoms, but that was it. So goal reached. Johnson & Johnson is definitely a vaccine that I will take any day and get my family vaccinated with it too. Okay, vaccine distribution. I think we are working on that really, really greatly as a nation. We can see here we're now at 25%. Given at least one shot. You can see here doses used, 79%. These are not getting old, these are not thrown away. We really kind of make a big effort to use every dose that we can get out. North Carolina is just on par with the total of the United States here, even a little bit higher with dosage that's used. So fantastic going forward. I think it's a great kind of complement to the government and to the state and what they have done in a very short time to help everybody to get the vaccines out and into the arms of folks. So in North Carolina, that's kind of the groups here. And we started, of course, with the healthcare workers and long-term care staff and residents and older adults. Now it's here at this number 4. So we are kind of walking through it. And we are walking through it faster than we actually kind of thought it would be happening because we are getting more and more vaccines actually kind of that we can give into folks. So the last one is actually with adults with medical conditions that causes a higher risk for these folks if they're getting infected with COVID-19 to have a severe outcome. So what are we doing at Wake Forest Baptist Health here? And these are just a few numbers from March 18. So total vaccination received 62,000. And you can see here kind of how that is shared, kind of with first dose, second dose, and also shared with health departments. So you're working with Forsyth County, Guilford County, etc. We are sharing our vaccine that we are receiving to make sure that everybody gets it. Very quickly. So vaccines administered here for employees, 13,000 first dose and 12,000 the second dose. We started off with the Pfizer BioNTech and then got the Moderna. And I think we will get the J&J too, the Johnson & Johnson. We also then focused on our patients, especially the ones that are in the high-risk groups. So 11,000 already received their first dose, and the second dose is 6,000. And we also have these mass vaccine events here. The last one was actually last weekend, that is not even here. And we got actually 8,027 vaccines given. So big push from the community, and we are happy to be part of that. So big question is, does the COVID-19 vaccine reduce the spread of the coronavirus? Because if it does, then actually everybody will be happy to go back to normal and without masks and social distancing, etc. So first, a few kind of items there. So asymptomatic patients are responsible for 24% of transmissions. That means somebody that is not sick, but carries the virus and spreads it. And as I said before, the more the virus circulates, the higher we have a risk of mutations happening. And we are seeing these mutations are popping up. Yeah. And vaccines overall can prevent illness, which they should, and or transmission. But the transmission part is kind of something that is once in a while working and once in a while not working. So we know that measles, for example, the measles vaccine is very good to pretty much kind of stop the infection and the transmission. So if you got your MMR as a kid and you are exposed to measles, you cannot get sick with measles, but you can also not spread measles. Hepatitis B vaccine, for example, does not actually kind of prevent the spread of it. So if you already have hepatitis B, you can still spread it. Preliminary data indicates that we have a reduction in transmission from these vaccines. So that these are all kind of great. And I think the prediction is that in April, we know more about how well they actually reduce the transmission of COVID-19. So for now, unfortunately, following the CDC advice and good practice, we have to still keep doing what we have been doing with social distancing, frequent hand washing, and masking. So some vaccination questions. So the common side effects you can get when you get your shot in your arm is pain, redness, and swelling. And then throughout the rest of your body, you can feel a little bit tired, have a headache, muscle pain, chills, fever, nausea can also happen. However, these are more rare. So usually you get your localized pain and redness and swelling in your arm, and that's pretty much it. And so these are kind of questions that came up here. Why do we have vaccines that require 2 shots, like the Pfizer-BioNTech and the Moderna, and then we have some that just have 1 shot, like the Johnson & Johnson? So this is all based on the first studies that they did with these vaccines, and you always kind of go for the safest way to produce immunity. So they saw in these studies that the first immune response that folks had after the first shot was a lot lower than expected, or that they would like to see in these vaccines. So they were kind of around 40, 60%, etc. So the second shot, the booster shot, what we call it, actually kind of really kicked it up, and we reached then the 94% and higher efficacy there for these vaccines. So however, there are new studies coming out that look at what is really kind of what's happening, because the indicators that we are using to look at the immunity that is developing against COVID-19, these indicators are not the biggest and greatest and what you ever wish to have. Our immune system is very complex, and we are just kind of looking at one tiny piece of it. So I think as we learn more, it appears to be that some of these vaccines that require just 2 shots, that we can just use 1 shot to get the same effect in keeping people out of hospitals and having severe illness. So then the question came up, if you actually had COVID-19, and the recommendation is after you get through it that you get actually a vaccine shot, because again, the vaccine provides a very good protection. It's a little bit broader than what you maybe went through with your natural infection. So the localized, and what are the side effects there? Do I have to be more afraid because I had before COVID-19, and now that maybe kind of makes me more kind of prone to have more side effects? So the localized injection sites like pain, redness, and swelling is pretty much the same. Very small studies, but they looked at it and they didn't see kind of really a lot of difference. Patients with pre-existing immunity disorders, they encountered a higher frequency of systemic side effects. So your tiredness, your headaches, chills, and fever, muscle or joint pain. But again, nothing to really say, okay, well, we have to balance the risk from what it is. These side effects are really something that I think we can easily deal with if the consequences are that you're hospitalized, you're on a ventilator, and you may actually die. So the recommendation right now, I want to add that, is that only 1 shot is needed there. Again, kind of coming back to that we are learning more as we kind of go along and study that. So how effective are our current vaccines against variants? And again, as said, it is all kind of looking at the spike protein, and that is based our vaccines on the original virus that was first detected in Wuhan, China. And it appears to be in the studies that we have seen, these are small, but again, that the South African mutant, the B.1.351, that the vaccines are less effective against that one. So the Novax, J&J, and AstraZeneca variants. The BioNTech seems to be a lot better than that, and the Moderna too. So there may be differences between the types of vaccine, if it's a messenger RNA vaccine or if it is a double-stranded DNA vaccine. But again, what is really kind of important is to say that most of these studies are also laboratory-based. So we're using serum samples and looking at the antibodies that are contained there in them. And so that's not kind of the best way to do that. The real world experiences are really kind of something that we are looking into, and looking at the Johnson & Johnson. It showed that given against that variant, it was also significantly lower hospitalization numbers than placebo groups. But more to come with that. And again, I think one big example is Israel. They have been fantastic in their vaccination rollout. So their population is pretty much further ahead than any other country. And they are dealing also with one of the variants, the B.1.1.7, that was first recognized in the UK. And it does not appear that the messenger RNA vaccine, the BioNTech, is anyway faced by that new variant. So it is also very effective against that. So the next steps for that here is, again, keep the infection prevention measures in place, so social distancing, masking, and hand hygiene. And then the vaccine manufacturers, they are working now on modified vaccine versions to target variants. I don't know if that will be necessary, that we have another shot of these, but it's definitely good to prepare for that. And when they are becoming available, that we can give booster shots to folks to make sure that this is happening and they are fully protected. Will there be maybe an annual COVID-19 vaccine like what we encounter with influenza? It may happen. I really don't know, and I cannot really say for sure. Again, the mutations are definitely something to worry about, the variants there. And that is the same why we are doing it for the seasonal influenza, that we are looking actually at the variants of influenza strains that are floating around, and then develop vaccines that are fitting to target exactly these variants that are going around. So the same may happen for COVID-19, but I hope not, and that we can pretty much eradicate that strain and then be done with, like what we did with actually the first SARS-CoV virus that was in the 2000s that we had that, and we eliminated that pretty effectively, and it's not circulating at all. So what will be next? These are some slides to show you kind of what happens if we kind of let down a little bit our guard, or what happens if we have actually vaccines and can give them away pretty easily. So the 7-day average, this is actually really a success story. And you can see here 1.66 million newly vaccinated people. And you can see the 90% will be reached by the end of July. So this is fantastic with the current pace, no other vaccines pretty much available. We just push it out and we get people vaccinated. And again, we try to reach herd immunity. So the more people are vaccinated, they build these cocoons around people that are sick and infected, and they cannot spread, these people cannot spread the virus anymore. So this is kind of what we try to aim at. And there are discussions, when do we reach herd immunity? Is it 70%? Is it 90% that we need? So nobody really knows, but I think a good guess is probably between 80 and 90% that we need vaccinated of our population to stop the spread of COVID-19. So what happens if we actually kind of go on like that? And these are older slides here, where we even had kind of a little bit lower one here with the current pace of 1.7 million shots per day. Actually, that's quite what we had before. And you can see here the number of people that will die is around 100,000. And in July, we will reach the threshold of total immunity. That means folks that are vaccinated and folks actually that had the natural infection. If you actually kind of get to 5 million shots per day, we can reach our threshold in April. Yeah. So which again kind of shows you, if we really kind of roll that out quickly, we can make a big headway. And we will save 20,000 lives, at least with that. So I think that's something to push forward and really get people vaccinated as soon as we can. So if we are now relaxing social distancing, because we really don't like to be distant and wearing masks and all that hand washing. So if we kind of keep in pace here, that's pretty much what we had. July threshold, 100,000 will die. And then if we actually kind of end precautions now, so everybody can go to the restaurants, to the bars, everything that you want to do, to the beach and celebrate there. So we will reach the threshold of immunity faster because a bunch of people will get infected. However, the price that we are paying is 220,000 additional deaths. So that's kind of the societal price that we pay if we leave social distancing behind. Okay, new, more contagious variants. So, and that's kind of a big question here. Again, 100,000 here by July reached. What does it mean if we have a more contagious variant with precautions? So keeping our social distancing. We again reach it in July, but we will double the number of people that we will lose to COVID-19. So a few slides about dealing with misinformation, because I think you will be bombarded by questions saying, you know, what is this? And look, I read that on the internet, and the internet always tells the truth. We all know that's not right. So how do you kind of react to that? And I found that, and I think it's kind of a really nice thing to do, to maybe kind of go away from this debating and stuff that has been read on the internet, but looking at the source where the information comes from. Yeah, so we all don't have a lot of time. So if I spend the rest of my day kind of searching what that one person said, I wouldn't do a good job. And I really don't want to do that anyway. So, and you can see here, disinformation is created to capture our attention. And we have been taught to question pretty much and develop critical thinking capabilities. And all that stuff is giving us really kind of that we have to spend time on it and we have to really have attention for it. So our resource time is scarce and we should actually use it better. So what you should do, or what you can do, what I suggest is stop, investigate the source, find better coverage, and then trace claims, quotes, and media to the original context. So the folks that create the disinformation, they are highly intelligent. They use a tiny bit of truth here and there, sprinkle it in, and then the rest is something that you can say, oh my goodness, where are they getting that from? So really, again, the source is really important. So stop overthinking what you see online, go to the source. If the source is not reliable, then you know kind of you can actually dismiss it pretty quickly. So an example. So I pulled that from the internet. Yeah, so children's health defense. So first of all, it has children in it, it has health in it, and has defense in it. That's fantastic. Yeah, who doesn't want to defend the health of our children? Yeah, so shame on us if we don't do that. Yeah, and it's exposing the truth. And here is kind of the safety of the system that the CDC has implemented, and they failed, and all that stuff. And so it's pretty much kind of damning and vaccines and what the FDA does and the CDC and the governmental agencies is really kind of subpar, and we should condemn that. So let's take a look at it. Let's kind of look at the internet, and let's again kind of a source, investigate the source, and Wikipedia results. Don't say all the time you should trust Wikipedia, but it gives you pretty good information. So it says Children's Health Defense is an American nonprofit known for its anti-vaccine activism. Much of the material put forth by the organization involves misinformation on vaccines and anti-vaccine propaganda. Yeah. And they give you references to check that even deeper if you want to. So find better coverage. Vaccination information, first 4 results. Vaccines and immunization by the CDC. COVID-19 vaccine updates and information, Johns Hopkins University, great website. Even the Pfizer-BioNTech website has FDA information. Vaccine and immunization by WHO. These are the first 4 results that pop up. Use them. This is what you have to do if you look at folks like that here. Then trace the claims, quotes, and media to the original context. So again, be aware there's a lot of misinformation and disinformation out there. Use actually the internet to look at the sources, and you can determine pretty quickly if that is a legit one or is it something that you have to question a little bit more. So talking to friends and family about COVID-19 misinformation. So this information is really kind of hard because it's if you have family and friends and relatives that once in a while you kind of the uncle or whoever, the aunt that comes up and you say, oh my goodness, where did they get that from? And these are pretty much kind of information that I got to look at that. And please look at that. If these folks appear to be unstable or tend to have violent behavior, stay away. Yeah, that needs professional help, and I think then it's smart to just say yay and walk away. Ask where the information is coming from. If you have relatives and family members that you want to talk to, or even your congregational members, and ask them, where did you get that from? And then kind of use the SIFT system to look at that. Explain to them how Google works. The algorithms and Facebook and all these stuff, Instagram, something like that, the algorithms behind that are just based on hits and links. And the more outrageous it is, the more hits and it gets, and the higher it gets into the stream. It's also, as we all know, kind of once you're getting into it, you're in this bubble and you get more information fed in the same direction. So I would say that's pretty bad, but I think it's trying to explain that to people may help them to also kind of realize what they're dealing with. Create cognitive dissonance. Yeah. So there are some conspiracy out there. Yeah, absolutely. Watergate, etc., Jeffrey Epstein network, etc. All that is true. But the question is, how did it play out? Yeah, whistleblowers, journalists, then looking at that, looking at the facts. Usually the disinformation campaigns do not hold up to that. They yell pretty much everybody is against them. And if they are kicked off the bigger media sites, they say that they are kind of seen as the enemy, and then they have the wagon train mentality to all kind of lock up and say, oh, terrible, everything else is. So just talking to folks saying, you know what, yes, I recognize there are conspiracies, but look at how it actually plays out. Does it play out like that in the setting that you're talking to them about? And maybe kind of creating there some thinking on their side. Avoid appealing to authorities. Don't say Dr. Fauci has said, or NIAID or CDC or something like that. Usually that doesn't go over well, and they pretty much dismiss that because that is the enemy. Yeah. Debunking is difficult. If you have a believer, yeah, that may be really part of their cultural and political identity. Yeah? So it's very hard to get through them if you have that. If you start to question then the conspiracy theory through fact-checking, why don't you go to that website or something like that, or look at that website? That can be interpreted as a personal attack. So you have to be very careful. The person has to do it by themselves. You cannot do that for them. And again, questioning them is more productive than stating how stupid that all is, and that they shouldn't actually not read this or that. The last thing is, don't debate on Facebook. Yeah, all these social medias, websites, etc. They are prone to bring out the worst in us, and if then virtual, like what we are doing here, or in person, that's the way to talk to folks about that. Otherwise, I don't see that you can really reach anybody, because everybody has a keyboard and types furiously into it whatever they want. Mocking and scolding don't work, as we already know. Yeah, so never dismiss them outright. It's stupid. If you have a true believer that you think you cannot really get through, then keep your cool and just be gentle, compassionate, and patient with them. The other thing is also know when to walk away. Yeah, there are some folks that you start the discussion, etc., and you realize, you know what, you're not getting anywhere. And so if they are kind of concerns about their health or their safety, if they are kind of really out in the left or right field, then usually professional really should be contacted for help for that. There's also part that you have to protect yourself. Yeah. So you cannot get into a fight there with somebody, or it cannot be so emotionally draining that you suffer from it. So you have to know where your boundaries are, and also where your health actually starts to be affected by that. So, and then again, be ready to walk away when you see that. So a few thoughts on congregate settings. That's the last few slides that I have. So worshiping, singing, and eating, and all that stuff that comes up. So what we know is we haven't reached herd immunity. We are 25% vaccination rates there, and we have variants that are popping up that may actually be, that our vaccines may not be as effective against. So again, these are kind of the warning signs. Outdoors is always better than indoors. So discourage symptomatic members from attending. If you want to do that, then keep the social distancing, hand hygiene, and masking measures in place right now. I'm very sorry to say that, but that's the safe thing to do. Singing and choir practices, again, multiple studies have shown that singing is a high-risk activity and can spread COVID-19 virus very well. And you really don't know who is actually kind of vaccinated, who is not vaccinated. We even don't really know if vaccinated people can still spread the virus. And we know that people that do not display any symptoms, 25% of them still can spread the virus. If you want to do that, do it with these special singing masks that are available, at least 6 feet distance between the singers, and increase ventilation. Open windows. Really, windows are out of fashion. Everybody has air conditioning, but a window is a really good thing. And right now, spring is around, so it's fantastic weather to do that. If food is being served, prepackaged food and beverages, not the buffet, and again, kind of the guidelines that we talked about before with masking and gloving for handling, etc. Then the attendings, etc. And so again, the distancing of the attendings, they cannot just go back, put off their mask, and then all eat together at one big table. If they have families, etc., sure, they anyway go home and do the same thing, so they can do that, but otherwise they have to be separated and socially distanced. So, and again, utensils, not be shared, and use disposable items, dishes, etc., plates, etc., cutlery, etc. is highly recommended. Summer camps, I would say probably the next 2 months decide where we are going with that, if it is safe or not. I'm sorry, but I cannot give you a decisive kind of answer there. But I think we are at a point where it can go in both directions. If our vaccination campaigns are continuing like that and we are getting more and more people vaccinated, I think we have a chance to actually kind of stop that. But we have also the variants that are coming up there, and we have also the fatigue that is actually kind of loosening up some of our social distancing measures, etc., that can have devastating consequences, as I've shown you in my predictions. Okay, that's it from my side. Any questions?
Well, thank you, Dr. Bischoff. We do have some questions. You covered a lot of the questions posed ahead of time, but I just want to go through some, and if they're a repeat, I apologize. By the way, the people who've had COVID, you mentioned getting just one vaccine. Are they having more side effects from their vaccine than others who have not had COVID?
Yeah, so for the localized kind of for your redness, etc., and your pain and swelling that you may encounter after a shot in your arm, that's pretty much the same. These are small studies, but they showed that there was no difference between if you had before COVID or you didn't have COVID and you just got your vaccine. For the more general side effects like fatigue, muscle pain, etc., some of the studies have shown that people that had before encountered COVID-19 had a higher frequency of these side effects. So they may be more tired, have a little bit more muscle pain than ones that did not have the COVID-19 infection before.
The next question, you covered some, and it's in reference to the 3 vaccines that we have available to us now. Mm-hmm. One of them being a one-shot, the J&J. So we deal a lot in FaithHealth, the division I'm in, with historically marginalized populations, what we call HMPs now. And so what we've run into, and I've heard an echoing from people who are in the rural areas of North Carolina, you're giving us that inferior shot that doesn't do as well, and it's only one shot, and you're giving, the privileged people 2 shots. Can you speak to, because our religious professionals who are online today are going to run into that, is our population getting the marginal shot, and the other folks are getting the Cadillac. Can you speak to that, sir?
No, it is really not. And I think the data that we have seen for the Johnson & Johnson vaccine, so that's a single shot vaccine, are pretty much on par regarding hospitalization and severity of illness, which is really kind of what you're looking for in a vaccine. Yeah, how many people do need to go to the hospital even after being vaccinated and then infected? And how many people of these are actually kind of encountering severe consequences, like being on a ventilator to death, actually kind of really dying from the infection. And the Johnson & Johnson vaccine is very effective fighting that. So this is not a subpar, inferior vaccine compared to the messenger RNA vaccine. What we see in the data that have been published is that the immune response, the efficacy there was a little bit higher with the messenger RNA vaccines than with a single shot vaccine. However, at the outcome measure, how many people had to be hospitalized, how many people died of COVID-19 after the vaccine, there are no differences between them. So the Johnson & Johnson is a very good vaccine. So, and I promote that every time that I'm talking to people, because it is so good. It is a single shot, so people don't have to come back the second time. And it is very effective in exactly addressing what a vaccine should address. So a little bit of a side thing here, and I don't want to kind of push down influenza vaccines because I'm a high kind of proponent of that too. But if you have an efficacy of 50% for a seasonal influenza vaccine, you are celebrating, yeah? So again, Johnson & Johnson is a very good vaccine, and it's not inferior at all.
Thank you for touching on. I've received lots of questions away from here from clergy and others saying, well, you know, only 80 blank percent. Well, that's not 100%. I'm waiting for 100%. And of course, right now, I'm not sure that there's a lot here on earth that I count on 100%. But thank you for speaking to the flu vaccine. You know, and I actually literally was texted during your presentation a story apparently from the New York Times about 3 people who've been vaccinated who now have COVID. And you know, it's kind of like that you're missing the point. I don't want us to spend, because you covered a lot on vaccines, but here's one of the questions. And you talked about how to deal with vaccine hesitancy. And by the way, for the folks who are here, this vaccine hesitancy, I'm sad to say, exists also in the world of healthcare professionals, in surveys. But one question was, what role could the church play in encouraging vaccinations? And so if you don't mind, I'm going to take just a second and then pass on to you. One of the things that we were discussing in a meeting just prior to this is the role of the vaccine advocate in the church, in the religious community. And that is that your flock listen to you. They look at you as a role model, but you need to be more than a passive role model. I think with all aspects of health, this is an opportunity for us from the pulpit or with our feet and with our arms to demonstrate how this receiving the vaccine helps not only us, but helps others, and is part of our Christian mission that we talk about in trying to help the least of these. Any suggestions beyond that about how churches can be a center? I have a couple other things to add, but I want to make sure we get to you.
Yeah, I think I absolutely agree. I think it is a role model setting the example. And I think it makes such a big difference if one can say, you know what, I got the shot and I'm okay. It's by example, and leading by example. I think that's the best way how you can actually kind of lead a congregation and everybody else, every other team that you would like to actually have influence over. So I think this is one of these things where I'm really kind of hoping that folks like you are stepping up and really kind of helping us to promote vaccination. there's a lot of questions out there. There's hesitation. There is in the underserved populations, there is always kind of the hesitancy based on history. And I think this is hard to overcome. But I think without actually the leaders in these communities, there's no chance that we can do anything like that.
And so I'll add to that another aspect of ministry that we've seen is having not just the pastor, but having teams who help their flock find vaccines, because there is a digital divide here that's not always economic. That we have folks who are technology adverse, just like they're vaccine adverse people, and they need help finding a spot. There are places in North Carolina that you can go that the state runs where you can find a convenient place to get a vaccine. And I found that I could go just a half a mile away to a Walgreens or to a CVS and get a vaccine. But so churches are putting together teams and telling their flock, if you want a vaccine and you're having trouble finding out how to do it or how to get there, let us know. And so that's an active part of ministry that we can do to get people in and to get, people hate hearing this term, needles in arms or vaccines in arms would be another way. So that's a very active way that churches can lean in and help, especially folks who can't drive anymore. For the folks who are out of Winston-Salem, but also in Winston-Salem, public transportation, they do the best they can, but it's very difficult to get around the city. So these are active ministry things. Dr. Bischoff, earlier, or actually last year, you said you thought maybe July 2021 would be a time we could reconnect, and then not just you, but others I've heard fall. We have, churches have this tension of people who think we've got to get back together, The healthcare professional part of me is a little afraid that we're rushing things, without a warranty implied or expressed. Your thoughts about when we would actually be able to gather in total?
So I think the good sign is that with our increase in vaccinations per day, projections as I have shown you is pretty much kind of end of July that we will reach kind of 90% if folks are really kind of getting the vaccine, which will provide definitely herd immunity for us. So that's a very good sign. The signs of concern that I see are the variants that are coming up, and also the fatigue in folks saying, you know what, it's enough. We just celebrated 1 year of that, and it's not a great celebration. And so going into the second year, I fully understand that folks are tired of masking, of social distancing, of not going kind of into the normal routine that they have enjoyed before COVID-19 pandemic. I would really say that the next 2 months are decisive, as I said before, in which direction we are going. I truly believe that if we succeed with our vaccination campaign, we can win the race and we can open up to normalcy definitely in the fall. And so I made first the prediction of July 4th, I think. That's kind of one of these things that came up, that one of my colleagues propagated. I haven't talked to him yet, so I will get his opinion, but I'm a little bit more conservative in my take on it. I would say, look, if we continue to get our folks vaccinated, and if we reduce the pool of virus that is spreading within our community, I think we have a good chance to fight that if we just keep on going a little bit longer with our other measures, social distancing, hand hygiene, and masking.
So if I can add from my pastorate / organizational behavior aspect, that is, my fear is that if we try to gather too quickly and there is a resurgence and then we have to stop again, we'll do far more damage to the psyche and the spirit of our congregations than if we just stayed the course for those 2 months that you're talking about. So I appreciate that. There were some fairly specific questions about summer camp. I know you touched on summer camp, but one of the questions was, if the campers wore masks all the time, I guess, except when they're sleeping or eating, how does that mitigate? I know that's a tough call, but
Yeah.
is that enough mitigation, or do we still need to just wait and see?
So I think it's all a question of feasibility, and of course, if you have folks coming together in a summer camp, I think it's pretty tough. The summer camps that I attended, there was always a wild side to it. So kind of a little bit of the uncontrolled, which was the most fun. And so I would say it is taking definitely a risk in the situation that we are right now in. So again, I would say yes, if you can really, if you are sure that you can control a bunch of folks that really don't want to follow it, it needs only a few of them that really don't like whatever restrictions they have put in there. And then also sleeping arrangements, etc. Can they be separated? And and is that then really kind of fun for the folks that come to the summer camp? But again, I hope in the next 2 months we have a lot better idea kind of how that is going. I would still kind of, I don't want to encourage kind of planning for it, but let's say I would maybe prepare for if really it goes and we see a lot less COVID-19 and our situation is improving significantly, I would say let's go ahead and then have these summer camps, but they have to be first some changes before we can do that.
Well, and let me step in. If I don't risk my job at least once a day, I probably it's probably a vacation day, so I'm going to risk my job now and say, an important part of this would be the adults in the different cabins have to believe that this is important, that following these guidelines is important as well, because all it would take is 1 or 2 adult leaders who would say, don't believe in that, we don't need those masks, and don't worry about this. And if we believe in Jesus hard enough, then we could end up with a case of, if not infecting each other, or maybe so, and bringing it home. And so that's important as well. So it's the behavior of the adults that's important. So we've got time for one last question because we're running out of time here. So the CDC has now said that I can visit my 84-year-old dad, who's had both of his shots, and I've had both of mine. Actually, have tested, and my antibodies are showing, and that we can be together without masks, or I can be with someone who's low risk without masks. Does this port at all to larger groups? Because that's what I'm hearing from churches is, well, if you can do it one-on-one, then we could just have everyone who's had their vaccine come together.
So I think the CDC recommendations are really for households and family units, and so the vaccinations, I think it's a moving target, I would say. We also do the same here in the healthcare settings, readjusting and looking at vaccination and what the impact is. So for congregations, I would be waiting for the CDC to give more kind of recommendations as they learn also more about the impact of the vaccine there. I think it's definitely a step forward that some experts were kind of a little bit more critical of from the CDC when they said, you know what, now we can actually kind of allow folks from the same household, etc., and one party is vaccinated and even the other party is not vaccinated, etc., to see the grandchildren, etc., and all that stuff, which I think it's legitimate to say at that point, but I would not transfer, or we cannot transfer that easily to larger settings like congregations, etc., where it's a little bit difficult to control that. Yeah.
Well, then let me risk my job a second time today. So, and then I'll turn it back over to Ruth. And that is, I have been in a conversation where someone brought up that the Supreme Court of California said that restricting churches and visitation was a violation of the First Amendment. And my answer was very quick and maybe not this gentle. Just because it's legal doesn't make it a good idea. And doesn't echo who we say we are. I want to thank Dr. Bischoff before I turn it back to Ruth. He didn't know me before August. He'd seen me. He probably wishes now that he didn't know me, but he has done this phenomenal work not only in the everyday, but in helping the different communities of faith that I've asked him to speak to. So thank you so much, sir. And I'll turn this over to Ruth. Thank you, Ruth, also for inviting us.
Well, thank you, and thank you too, Dr. Bischoff, for all the valuable information. You've given us a lot of good information, and we're gonna edit this video as soon as we can and get it out so that folks can use it as a tool with their leadership groups. And just know that I think Keith is a great resource. And if some of you who are here have additional questions, I can connect you to Keith and he can help you. I'm sure he'd love to do that. So thank you all for coming, and we'll keep on keeping on. So thank you, everyone.
Thank you. Take care.